TMA is a very rare complication of allogeneic transplant, typically associated with exposure to cyclosporin. It's a microangiopathic hemolytic anemia that can present quite fulminantly or insidiously, but typically with obviously hemolysis, renal impairment. You also get CNS involvement. And it's a disease that we really don't have any good treatment options for once you've withdrawn cyclosporin. And some patients don't respond to withdrawal of cyclosporin, and for them we do urgently need new treatment. So it's an area where we need trials, but the real challenge is it's such a rare complication. In a busy unit such as ours in Birmingham, we'd see about 1 case a year. And then if you think about recruiting to trials, there's only 1 a year, and maybe that patient is diagnosed at the weekend when the research nurse is not around. So I think one of the really promising features of the Trials Acceleration Program and the Impact Network, which pull together hospitals with funded research nurses, creating globally significant catchment regions in the region of 20 million, is that the scale of the network that you recruit from gives you a realistic chance of identifying these patients. So I think this is an important area where pharma need to recognize that the conventional model of approaching centers on an individual basis may actually be a very ineffective way of assessing new therapies. We're already in a couple of the impact and TAP studies working closely with pharma using our network and have demonstrated convincingly that recruiting to a trial from such a large, coherent and well-managed network is highly effective at delivering potentially registration standard trials. And one worries that the pharmaceutical sector is sometimes a bit stuck in the dark age, but they need to join the academic community in seeing that the future is in network trials acceleration programs.